Well, I was born in Pakistan and got settled in Iran. Went to UK, Canada for fellowship in neuroanesthesia and neurocritical care. And I worked as a faculty member in Tehran University of Medical Sciences, where I was a full professor. And at the same time, I had to look after the residents and the fellows of neuroanesthesia and neurocritical care, which was under my supervision. It was a year back that I got retired after serving for 35 years as a faculty member. And then after 2 months, my wife passed away. And that gave me a great shock. And as I said, it devastated my soul and body. And presently I'm with my children. I'm the chief editor of Archives of Neuroanesthesia, Archives of Anesthesia and Critical Care. I was the guest editor of Anesthesia and Analgesia, American journal, the oldest journal, I believe. At that time, Professor Schaefer was the chief editor. And we worked nicely. And during this time, I've attended many international congresses, symposiums. And as I was even invited as an examiner to Philippines for the postgraduate examination. We were 3 in number. One was from Australia, one was from, I think, Canada, and the third was myself. So I've traveled along a lot and learned a lot from others. I'm a small fry. Whatever I could do, I've done. And now I am 71 years of age and looking after my 2 daughters and 1 grandson. Effects of surgery under general anesthesia during pregnancy include the risk of deep vein thrombosis, pulmonary embolism, aspiration because of decreased esophageal sphincter tone, decreased gastric emptying, increased gastric pressure, hyperemesis. And all these risk factors, they increase the risk of regurgitation and aspiration, which would eventually result in pulmonary edema and acute respiratory distress syndrome. It can also lead to spontaneous abortion and preterm labor. Now, these are weighed against the risks of an untreated oral or maxillofacial infection, which pose a much greater and dangerous risk to both the fetus and the mother. These risks include preterm labor and delivery with complications of a premature neonate, fetal death, maternal sepsis, and septic shock. All elective procedures should be avoided, preferably during pregnancy. But those which are necessary, they should not be delayed. For the pregnant female undergoing general anesthesia, surgery should be performed in a setting where an obstetrician is available for consultation and where anesthesiologists are familiar with the physiologic changes associated with pregnancy. Teratogenic and abortive agents should be avoided. This is the most important part on the shoulder of an anesthesiologist during the first trimester of pregnancy. Specific modifications may be needed as the gestational age of the fetus advances. But a collaborative, multidisciplinary approach involving obstetricians, anesthesiologists, and maxillofacial surgeons, all they provide the most appropriate management and treatment plan for the pregnant patient. A potential complication risk that is increased in pregnancy is the risk of deep vein thrombosis and pulmonary embolism due to the prothrombotic state of a pregnant woman. Physiologic changes that occur during pregnancy, such as increased clotting factors, increased plasma volume, increased venous stasis, decreased blood flow velocity, and decreased fibrinolytic activity increase the risk of DVT, which would result in leg pain, tenderness, edema, discoloration, palpable cord, and positive Omen sign, and subsequent pulmonary embolism, that is shortness of breath, tachypnea, hypoxemia, and respiratory distress. And these are all increased by twofold to fourfold during pregnancy and early postpartum. Other exogenous factors such as tobacco use, obesity, and immobility add to these risks. Venous thromboembolic events are still a leading cause of maternal morbidity and mortality. Early detection of DVT by using duplex Doppler ultrasound and initiation of heparin therapy have significantly reduced maternal mortality. Chest CT or a VQ mismatch scan are options for evaluation if a pulmonary embolus is suspected. So DVT and pulmonary embolism prophylaxis should be initiated upon the patient's admission with the use of support stockings, compression devices, and or subcutaneous heparin. A recent trend has demonstrated an increase in the number of cesarean sections, both in the developed and developing nations, for one indication or the other. The more plausible reasons for these surgical interventions include advanced and timely fetal monitoring, which diagnose the early fetal compromise, as well as increasing patient preference for the operative deliveries. Now it has been successfully well established that regional anesthesia is much more safer than general anesthesia for cesarean section. And the majority of operative procedures for delivery are being carried out under regional anesthesia throughout the world. Maternal preference, comorbid diseases, and urgency of surgery also determine to a large extent the type of anesthesia to be employed. Whatever the type of anesthesia is to be administered, the most significant aspect is the decreased number of maternal deaths, especially in the developed nations, as a result of advanced anesthetic care. Now, general anesthesia is indicated in a number of conditions. As I said, regional anesthesia is preferable, but there are certain conditions where general anesthesia is definitely indicated, such as patients' refusal for regional anesthesia. That's the patient's consent. Coagulation abnormalities, various contraindications of regional anesthesia, such as severe active infection at the back, neurological diseases, deformities of the spine, etc. The fetal compromise necessitating urgent operative intervention. The most challenging aspect of an obstetric patient receiving GA or the general anesthesia involves management of a difficult airway. The anatomic and physiologic changes during pregnancy make the scenario of airway management very challenging, such as soft tissue edema of the upper airway, weight gain, breast enlargement, increased mucosal vascularity with an increased propensity to bleed, as well as a high risk of aspiration pneumonitis, which in the past has caused many deaths. The hormonal imbalance decreases the tone of the upper esophageal sphincter, and therefore there is always a risk of aspiration in these patients in spite of adequate fasting. The increased gastric emptying time and increased intra-abdominal pressure, all together due to the gravid uterus, further enhance the risk of pulmonary aspiration. A rapid sequence induction and intubation is the method of choice for securing the airway in such patients, and numerous anesthetic techniques are available to suppress the stress response associated with airway manipulation and intubation. The availability of new supraglottic devices, such as ProSeal laryngeal mask airway and intubating laryngeal mask airway, have further eased the administration of general anesthesia and management of a difficult airway. Now, regional anesthesia is not only associated with avoidance of airway manipulation, but also has the advantage of avoiding the polypharmacy practiced in general anesthesia. Regional anesthesia also enables the parturient to remain awake during the surgical intervention and feel the first cry of the baby which is a good psychological boost for the orally anxious patients. Though spinal and epidural techniques have been equally useful, spinal is more common and significant when quick delivery is required, and also the cost effectiveness of spinal anesthesia is more comforting to the patient's relatives as compared with epidural, especially in developing countries. Epidural is more versatile technique as it can be used for labor analgesia, and if the need arises, operative intervention can be performed with the same catheter that has been introduced. The provision of a prolonged post-operative pain-free period makes this technique a first choice for many parturients. This method also has the advantage of extending the block height if the sensory level shows early regression during the surgical procedure. The increased costs, as well as a longer time taken for achieving an adequate block, are perhaps two reasons which impede this technique. The combined spinal epidural anesthesia has the dual advantage of a spinal as well as epidural anesthesia. It not only produces a rapid and dense block for surgery, but equally produces a post-operative pain-free period through top-up doses. The utility of this methodology is very significant, especially in high-risk patients, such as patients having cardiac disease, diabetes, and preeclampsia. Though many anesthesiologists prefer general anesthesia for eclamptic patients, graded epidural technique with titration of local anesthetic dose is equally good in compromising situations. The stable hemodynamics achieved are very essential considering the deranged pathology of the preeclamptic patient. If it develops, it's a tragedy. Anyway, unrecognized subdural or intrathecal placement of an epidural catheter and an intended spinal technique after a failed epidural analgesia are two main identified causes of high spinal block. The anesthetist performing these procedures must be aware of this severe and dangerous complication and must remain vigilant throughout with continual assessment of progression of the block in a well-monitored environment. Any abnormality or abnormally functioning epidural, that's the catheter, must be followed up closely. Development of a dense motor block of lower limbs during epidural analgesia using a low-dose epidural infusion is abnormal, and a high-level suspicion of intrathecal placement must be maintained. This suspicion must be shared with the entire team, looking after the patient and emphasized during handover care. Physical barriers in the form of prominent labels must be placed over the epidural catheter to prevent an accidental top-up with large volume of a local anesthetic. Preparation prior to performing any spinal block. One should ensure that the airway and resuscitation equipment is readily available. Vasopressors and drugs essential for an emergency general anesthesia must be within immediate reach. In obstetrics, the team must be aware of the location of a peri-mortem cesarean section pack. A designated emergency team and a cardiac arrest team must be identifiable. A clinician must be familiar with the locally agreed protocols to activate the emergency call system when it is needed. After a subarachnoid injection or epidural top-up, close monitoring of the heart rate, blood pressure, oxygen saturation, respiratory rate, and the level of neuroaxial block is not only mandatory, but it is necessary. Monitoring should follow clear written protocols. The frequency of observations should be determined by normal clinical considerations. In hospitals in the United Kingdom, clinical guidelines suggest that after each epidural bolus or top-up for labor analgesia, blood pressure must be recorded for 5 minutes, every 5 minutes for the first 20 minutes, and thereafter every 30 minutes. Sensory levels can be tested with ice cubes, ice packs, chloride sprays, alcohol wipes, or with pinprick. If they are interested in obstetric anesthesia, they can pursue. It's a very, very good specialty with concomitant risks of its own. If they are interested in neuroanesthesia or cardiac anesthesia or transplant anesthesia, they can pursue those goals. Now in Canada, the residency training is 5 years. In some countries, it is 4 years. We have got 4 years of training in residency. Now, some countries have still shorter periods, such as 3 years of residency training. But the residents during their residency training should avail of all the knowledge that is being imparted to them by their tutors, teachers, professors, because it is a very difficult specialty, and there are maternal deaths, there are deaths due to airway problem, there are deaths due to hypoxemia, and physicians are sued in the court for that matter. So in order to avoid that, the books must be read, the journals must be studied, and the students should have a vast knowledge of this great specialty.